Of viral corneal ulcers, herpes simplex, HSV, and varicella zoster. HSV1 is predominantly involved in children 6 months to 5 years of age is the most common age because before that they have maternal immunity. It is HSV1 secondary infection or recurrent infection that is causing eye symptoms. Lid involvement will give vesicles and blepharitis. Conjunctiva will get severe follicular conjunctivitis and corneal epithelium and epithelial keratitis. So mild discomfort will be there, foreign body sensation, redness, watering, blurred vision, photophobia like your corneal edema. You'll see a characteristic dendritic ulcer like I showed you in part 1 with rose Bengal stain. You can also call it a geographical ulcer when you have applied a lot of topical steroids and the enlargement of the dendritic ulcer has occurred. Corneal sensation will be reduced after this point. If the ulcer does not heal and the live virus has disappeared also, then it will be called a metaherpetic ulcer because of basement membrane damage. इसका margin stay नहीं होगा rose Bengal से. Stroma is involved with the virus, you will have deciform keratitis and there may be immune complex between the viral antigen and the host antibody which will feel visible as a Wesley ring. To diagnose apart from rose Bengal, you can use ELISA and PCR because it's a virus obviously. And to treat it, you can use topical antiviral agents like trifluorothymidine 1% eye drops every 2 hours or use vidaravine 3% ointment 5 times. Ulcer ka edges can be debrided. To avoid the spread of the virus, you can use a cotton tip tablet. In case you have HSV iridocyclitis, you can also use oral acyclovir. Low dose oral acyclovir 400 mg BD for 6 to 12 months can also reduce the rate of recurrent herpetic eye disease. Now, acanthamoeba. Suppose a patient has been swimming with contact lens. Acanthamoeba trophozoite will come and bind with a variety of enzymes to the corneal epithelium. Diagnosed with calcofluor white, you will see the cyst wall. Also PCR for amoebic DNA. Acanthamoeba treatment के लिए you can use chlorhexidine and PHMB, your azoles, your aminoglycosides and aromatic diamidine. Given as dual therapy with propamidine and PHMB or chlorhexidine and hexamidine, one being a membrane function inhibitor and one is a DNA synthesis inhibitor. We may have non-infectious keratitis wherein we have immune systemic disorders or localized allergic or immune responses like hypersensitivity responses in cases of vernal, flictennular or atopic keratoconjunctivitis. We can have trophic problems. So neurotrophic ulcers can be seen in diabetes mellitus where we have peripheral neuropathy or in leprosy also because of peripheral neuropathy. Or we can have cranial nerve 7 palsy, that is facial nerve palsy. As a result of facial nerve palsy, you will have lag of thalamus and your eyelid will not close and there you will have exposure keratitis. You may also have direct trauma or vitamin A deficiency which can cause keratomalacia. You can also have superficial punctate keratitis or superficial limbic keratitis. Treatment of most of these include topical lubricant eye drops, soft contact lenses or therapeutic bandage lens, topical antibiotics and cycloplegics for the pain, and for unresponsive cases you can have keratectomy or keratoplasty. Also note interstitial keratitis which is because of an immune response to the syphilitic antigen, not because of syphilis directly but because of the syphilitic response that is produced by the body itself. As a result, we have uveitis and keratitis secondary to the syphilitic infection. It can be treated by giving penicillin for syphilis, topical steroids for hypersensitivity. For the uveitis, we can use cycloplegics and lubricating eye drops as in all cases. We also have chronic serpiginous ulcer or rodent ulcer called Mooren's ulcer. It is a rare peripheral ulcerative keratitis. May be possible in autoimmune response to a genetically susceptible individual. Treat with topical steroids or conjunctival resection because it decreases the inflammatory mediator.